Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
No.
Hey, George, good to see you. It's Tuesday morning. We have another great guest with us today.
Yeah, today we have Dr. Gail Schonfeld, one of the greats from the Hamptons. I've known Gail for many, many years. She works in New York, but on the other side of Long Island, which we visit in the summertime. And her topic today is going to be what it's like to practice in rural medicine in a ritzy town like the Hamptons. And that should be an interesting dialogue.
Definitely. Welcome to the show, Gail. It's good to see you again.
Thank you. Good to see you too.
We always start by asking, why did you become a pediatrician?
That's a good question. I did not enter medical school thinking I was going to become a pediatrician. I was going to become a surgeon. I did not like the surgeons. I did not enjoy my surgical rotation. I felt the hazing for 5 years was more than I was going to be able to handle. And then I had an excellent preceptor my third year of medical school in pediatrics. And I just really enjoyed my time there and found that I had some skills interacting with children and, decided to go that route. It was a change of heart and, my third year of medical school.
Yeah,
Wow.
interesting. Just
Why
the
did
same
you-
story that everybody has, right? Pretty much.
Yeah, everybody. No, some people they want to be pediatricians from the very beginning.
I have yet to find them.
Everybody's got a different path.
Yeah,
Why did you choose to practice out in the Hamptons?
yeah.
Well, I always knew I wanted to go rural. I don't like the city. I still don't like the city. And I grew up in suburbia. I didn't really like suburbia, and I really do like rural areas. And I did interview in some rural areas, but there was a letter that was sent to my residency program, and that was on the wall in the chairman's office. And it was pointed out to me that they were recruiting a pediatrician in East Hampton, and there'd been a woman who'd been here all of her career, practiced out of her home, and from what I have been told was very good. She died. She, lived a good life. She practiced her entire career. She got breast cancer and she died. And then there was nobody, and the town was looking for somebody. They were recruiting. I had been interviewing in different places, and I came out here to meet with people that were helping to recruit. And it was just, it's very pretty out here. It's a nice area. And as rural areas go, this is better in some ways than most. And so I said, yeah, I'll give it a try. I had not been planning on going out on my own. I wanted to join a group. But this convinced me to do it on my own. And again, another last minute career choice to go into solo practice. And I really had intended all along to build up a group. And I did, take on a second person after 2 years. But yeah, that was, in retrospect, very brave of me to start practice without any preparation. It was.
Did the hospital provide you with some management help to get started, or did you just do it on your own?
Zippo. They gave me Zippo. So there was a group that recruited. I thought they were going to help me. They allowed me to rent a space, the last of the space that was available in the medical building that had existed at that time. It was a very small amount of space. And they decided, the woman who was doing the recruiting owned the building, and she was going to decide who got to rent it. So they interviewed me and decided they were going to allow me to rent it. The town supervisor came and met with me, took me out to lunch, lovely restaurant, lovely woman, introduced me to the president of the local bank and suggested they'd lend me money. And they said, where's your collateral? And I'm like, I got nothing. And they said, yeah, no, not giving anything. So no, nobody did anything to help me. I didn't, as it turns out, well, I did need help. I didn't realize how much help I needed, but I borrowed some money from my parents, and I didn't need a lot because I started seeing patients the day before I opened and was swamped like immediately, seeing 25 patients a day my first week in practice. So, I mean, there was a deficit, there was a need, and I filled the need, and immediately, I was busy.
If you
Well,
build it, they will come, right?
yeah,
I
That's true
believe
when
it.
there's, nobody else around. Yeah.
it-
Not true for every practice you start up. And so that wasn't the problem for me. The problem was figuring out what to do on my own and, trial by fire.
and does the hospital in the Hamptons deliver babies?
There is a level 1 nursery. There was a level 1 nursery then. That was actually kind of an interesting story. See, I will tell little side stories. So there were 2 other pediatricians on staff at the hospital. One was board certified, the other was not board eligible. And they were taking care of all of the newborns. They were older and didn't really have any neonatal training. And I got there and there was really nothing. I mean, nothing. And a short time after I arrived, I remember I was in the doctor's lounge and I was paged to the nursery, and the doctor, who was board certified and chairman of the department, asked me on the phone what was the constant in the equation for bicarb replacement for a, infant in respiratory distress. And I said, gee, why do you ask such a question? And I went to the nursery and there was a baby who he had intubated. The PCO2 was 60 and he was going to get bicarb. And the respiratory therapist was standing next to him, like jumping up and down, crawling out of his skin. And I said, would you like some help with that? You want me to adjust those respirator settings for you? And so I did that. And then he asked me to give a series of talks on, neonatology to the department, which was him and the other guy. And so we did that. And so they then sort of started asking me for help with all of the bad babies. And I mean, they did transport all those kids, but I mean, you have to stabilize them. It takes hours for the transport team to come in a rural community. So we threw that in there. And then there was a local healthcare professional who gave birth to a 34-weeker. And I kept him. He had a little apnea. I had a little, had him on theophylline. And, I put an IV in him. And every time he came out, I drove the 13 miles back to the hospital to put it back in. And then I got invited to a meeting of the board of the hospital. And, I was young. I didn't get it. I didn't know. I said, yeah, okay, I'll come. And they wanted me to talk on something for 5 minutes. So I spoke about this baby, and the father had taken some slides, and he gave me permission to show them, and I did that. And they said to me, well, how many of those, it was a stabilizer, just, overhead heating thing that we have? And I said, just the one. And they said, okay, thank you. And then the next morning I was making rounds and the nurse came over to me with a catalog and she said, Gail, they told me to give you whatever you want. Did you want to order anything? I'm like, okay. So, respirator, chest tubes. I just ordered everything and they just paid. So
Wow.
I started the program there, and I took call for 20 years. Every third night I was on call. And if there was a sick child in the emergency room or, a baby that was born with a problem, then I had to drive to the hospital 13 miles and stabilize the kid. And there was nobody but nurses that were there till I got there. And that is rural medicine.
Yeah.
Wow.
So did you order a Tesla too on the hospital?
Matter of fact, I got a Datsun 280ZX, and I floored it one night just to see in the middle of the night how fast it would go. I mean, I got up to 100 on the highway. There's nobody in sight. One night I did get pulled over by the cops and I got out of my car and said, I have an emergency at the hospital, just got back in and took off. But yeah, they knew who I was and nobody bothered me. And back then, I mean, if you got called to the hospital in the middle of the night, there was nobody on the road. You could drive fast.
She's like Doc Hollywood. Remember that movie?
Yeah. Yeah. And
Bit of a cowboy, yeah.
what unique challenges have you found doing rural medicine, and especially on a coastal town, right? Because rural medicine in a non-coastal town must be very different. You must have influx in the summer of a lot of people that are not there in the winter.
Yeah, so this is an interesting mix um, in a number of ways. The economics out here, people don't get it. And there's a group of Hispanic immigrants who are more or less invisible, who service the needs of the wealthy. And I think of it kind of like a feudal state. You know, there's the very wealthy, and then on their estates are the very poor. And I do have about half of my practice is Medicaid or Child Health Plus, and that very wealthy small contingency. I realize that I have a lot more wealthy patients than most people do, but they really are a small part of the practice. And there used to be a lot of more middle class out here than there is now. Things have really changed in the economics as the years have gone by. But in
And
the summertime, the population doubles. And I don't know if that's as true now as it was before the pandemic, because a lot of those people came out and stayed. It was very challenging. And so we had a seasonal practice, and we would provide, like you do, George, your urgent care services. And this place functions like an emergency room. We are 13 miles from the nearest emergency room, which has no pediatric emergency room physicians. It's all, general ER, and not really particularly expertise in pediatrics. Just leave it at that. And so, yes, when I took call, I was called to the ER a lot. I, provided consultative services as well. But I provide a lot on site. So when I moved into, well, I tell you, the first weekend I was in practice, 1982, and really, like, I was not prepared for this. It was July 4th weekend. You finish in June and you start in July. And a teenage boy, I was about, I think, 16, came into my office, and he didn't actually walk because he was being dragged. He had lost consciousness, and he was in anaphylactic shock. And he was with his aunt and uncle. He was visiting them, and he was at the beach, and he was in the water, and he walked over to their blanket and collapsed. And nobody knew why. And they brought him here because that's the way this place is. And he was very swollen. His blood pressure was 60 over zero. And it was a jellyfish sting, and there was a mark on his shin that kind of gave it away. So I gave him epi, I put a line in, I gave him some fluids, I gave him some steroids, and I transported him to the hospital. And then I said, okay, I didn't have any of that stuff. There was a PA who worked for internal medicine guy in the same building down the hall, also ran the ambulance corps. And he came over and he said, Gail, would you like some epi? And he handed it to me. Gail, would you like an IV? And he handed it to me. And so then next morning I ordered all this stuff, and I realized that I had to be prepared to function as an emergency room. And I have provided critical care in my office. I've actually intubated twice in my office. I've never actually defibrillated, but I have run codes in my office. Yeah.
and
That has to
so
be disruptive to your office.
Yeah. Yeah, it is. We helicoptered a kid out this weekend. It is what it is. It's part of it. You do much, much, much more in a rural practice than you would in suburbia, where the emergency room's down the block. People would never think to come to the office critically ill if the hospital was
That is true.
readily accessible.
Guys, back in the 60s when our practice started as Rice and Brown and Kaplan, I heard of stories like this because this was all farmland. So I guess in the 60s, Long Island ended at exit 52. The Hamptons wasn't even thought of yet.
There
Um,
wasn't much here then.
Yeah, so they did. I heard stories where they had like, you know, poisonings, organophosphate intoxications. They managed in the office, seizures in the office. He would do home calls. I mean, he was the only one out here. Like I said, the Long Island Expressway ended at 52. That's where the office was. Now it
Yeah,
goes out to 70 plus. So
73.
I guess fast forward 20 years to the 80s when you were there,
Mhm.
the same thing repeated. So now it's
Yeah, I
probably
mean, it was very
changing.
rural. And there wasn't a lot out here. And I mean, I remember my first year in practice being called to the ER for a 1 week old, and the doctor said to me, "Take your time. You know, it's no big deal. He had a fever, and he seems fine, but he's breathing kind of funny, and
Yeah,
maybe he's got pneumonia." That was agonal breathing. And that
yeah,
was group B strep sepsis and
yeah.
meningitis. And I did, speed in the car, and I should go through some red lights. I don't know, take your time. A 1 week old with fever, I'm
Yeah.
like, no, no, and I remember that helicopter transport, waiting for the helicopter to arrive and the kid just tanking. The kid was just going down. And I was so scared that kid was going to die before she made it
Well,
out of my hands.
fortunately, we don't have to do this kind of medicine anymor.
Well,
Not
she
much.
But
does.
I'm sure there are parts of the United States that actually they still do this.
Well, Gail still does.
No,
Well,
really, with
I
the
don't think she does
helicopter on
helicopters
Saturday.
anymore.
Huh?
No, I still sometimes do critical care in the office, maybe once or twice a year.
Well, and so how do you handle the volume surge in the summers? Do you hire locums or up staff? How do you do that?
We increase our hours and we don't do checkups. We don't do checkups except between 8 and 9 in the morning for the under a year-old kids. We just really just do urgent care all day long.
All that and um the very wealthy, are they there just part of the year, or are they now there most of the year?
There are some that are here year round. So uh, I'm thinking carefully what I'm allowed to say here. So the widow for Stephen Ross of Warner Brothers Communication, Courtney Ross, I guess she was his third wife, and his widow was interested in early education, and she founded the Ross School out here. And it now has international boarding students, and the tuition is incredibly high. And there's a number, I am the chief school physician. There's a number of very, wealthy children from all over the world who attend school locally. And more and more people have moved out and spend more time in their homes out here. And certainly since the pandemic, that's been a huge increase of year-round
Yeah. It is a
population.
very nice place to visit. I've been there, but that road with all the traffic is like, ugh, forget it. It's worse than Manhattan.
Yeah, there was a campaign back in the 80s, and I was kind of, naive, and I just sort of watched from the side. It was called Halt the Highway, and they were trying to build a big highway so that people could make it out easier, and the local people didn't want that to happen. They didn't want any more people moving to the area. They wanted to keep it, rural, and clearly that didn't work out. And now we just have traffic problems. That was very short-sighted. And now
So
it's really
with all these you know people from all over the world and all these people that just come to visit, um how do you can't participate with every insurance plan in the world. How do you make money?
um well, I can tell. No, I guess I can't tell you. But the Ross School students do have an international insurance plan that pays me very well.
Okay.
And I got to negotiate those rates with the school, saying, give her what she wants. And so I do get paid well for taking care of those children, and they all come with a credit card for anything that's a non-covered service, which has not really been a problem. And there are international insurance plans, and people get reimbursed. It's kind of very similar to the way it used to be before managed care. But
But for example, in Maryland, there's a Blue Cross product called Blue Choice, which is a closed-end HMO. So if you don't go to their HMO provider, there's Zippo reimbursement. And in Northern Virginia, there's an Aetna product too, which is exactly the same. It's very closed. So you can't. I mean, you're not going to enroll with Blue Choice HMO and Aetna from Virginia. What happens to those? How do you got to take the cash up front?
It credit card on file. Doesn't come up all that often, and the HMO products are more affordable, but the people who are summering out here are generally not buying the more affordable plans.
Okay, so they're in a national PPO.
Or a very well-paying plan. Now, I again, thinking carefully about what I can say, there was a time, a number of years ago, I guess about 20, 25 years ago, when one of the doctors left the practice and I needed to shrink the practice rather quickly. And I looked at the insurance plans that I had and I decided to drop the lowest payer. And when I did that, lo and behold, all of a sudden people would negotiate. And I kept doing that until I got to one that would not, the evil empire of all insurance plans. And I looked at the panels. And before I made my decision, am I going to make good on my threat or am I not? About a third of the people were summer patients, we call them, that had a PCP elsewhere, but, came out here. And about 2/3 of them were local. And those patients can't afford to pay out of pocket. But the other patients, if you're non-par, doesn't faze them because generally their PCP is non-par. And they're used to concierge medicine where they pay a high fee and get a type of service that they want to have. And, that was very popular in the day with a lot of guys in Manhattan that didn't take any insurance, and they were very sought after, well respected, and would spend half an hour to an hour per patient. And it's kind of like the concierge practices of today. They just didn't take insurance. And people could bill for some money back on the insurance, but they just paid. And then they came here and found out I took the insurance. They were great. The parking's better and we don't have to pay anything. Let's do our checkup here every year.
Yeah.
So, some people pay out of pocket, but there's really just not a lot of that. It's strange.
Wow, I really would have thought that in the summer you would get a lot of people just pay their bill and then deal with their home plan somewhere else.
Not that much, really, not that much.
Well, and what are some of the advantages of practicing in the Hamptons, other than you love the area? I mean, you have to like rural America.
It's really
and the
nice.
beach.
I do. I mean, little bunny rabbits on my lawn and the deers and the turkeys are really kind of taken over. It's very strange. A lot of wild turkey out here now. I like, being far from my neighbors and having a large backyard. I mean, I do like rural medicine. I think there's some nice things about the rural lifestyle, and more so in the past than currently. People are less mobile, and I'm starting to see the third generation of patients. So I really know my patients. And it's really nice to watch a kid grow up and then as a parent with their own kid, and there's a real rapport. When you talk about the primary care advantage, when you've watched a child for 10, 15 years, they really do trust you. It's a big advantage.
Relationships, I guess, right? So I guess.
I mean, when the grandmother was the mother and she says to her kid, listen to Dr. Gail, she knows what she's doing, instead of having to prove yourself to the grandma. I mean, it's huge. It's great.
Yeah.
I think that's one of the nice things. But the other thing is I get to do things that I would not get to do if I lived in suburbia. And I think for many people that would just be very stressful. I get bored easily, and I don't want to be a glorified nurse practitioner and just do the same things without any thought, just following protocols, not using my brain. And we do not refer to specialists the way other people do. So I, do have my limitations, but I will do a lot more with the child with complex healthcare needs with less involvement and more coordination of care with specialists than you would if you lived in suburbia or in an urban area. I get to think more, do more.
I think your local specialty care center is what, 2 hours away, Stony Brook.
Pretty much, yeah.
Yeah, and that's the closest one.
Yeah.
You have to think twice before you send them to.
Well, exactly. I mean, if I can do it myself, I'm not going to do it. And
I think patients appreciate that, but when they're down the street, there's 5 neurologists. What are you going to do?
I know it's different. It is different, and that is one of the advantages. And if you don't want to think, and you don't want to have to do any procedures, and you don't feel comfortable trying to keep up and do the work to stay current, then that's not an advantage.
Yeah, I think you have a lot of opportunities for collaboration with hospitals and with systems and things and insurance companies. If you're the only game in town, they're going to come to you for advice, I guess.
Assume that. I don't think that's always the case. I mean, I think you and I both sat on the board of Molina there when there was a all of doctors. Yes, so they did come to me, but it's not because I was the only game in town. It's because I hit the 97th percentile in all measures on the pay for performance.
Yeah, they like that.
Yeah, they like that. And so they sought my opinion. And the first time I met with them, they carried a big check and handed it to me. And they said, "How did you do it? We want to know."
Yeah.
And that's when I was put on that board. And that's when I started my integrated mental health program as a pilot program that they were looking for.
Right.
That had to do with me. I don't think that had to do with the fact that I'm the only game in town.
So you got, I mean, you're amazing. One, you have to keep up with things that change very rapidly, and you're not surrounded by a support, infrastructure to help you with that. But then you also have to run a business, and you still have a family life.
Well,
and
I think
things tired. You don't seem tired of it.
She never complains.
Yeah, you're amazing. I mean,
most people complain.
You're not the person I complain to. I do complain. Believe me, I do complain.
But you don't whine. Oh my God, why always me? I got to see. There's a new dialogue of these days.
Yeah, sometimes I whine. You got to catch me at the right moment. But no, I would not be whining on camera. I mean, there are moments, but before there was an internet, and before there was SOPM, and before there was online help, I really was stranded out here, and it was tough. It was tough. There were a few people who I knew who I could pick up the phone and call. Some of the subspecialists who would take my call at all times and tell me what to do and give me advice. And they're all retired now, and I feel like so stranded. I have to do what I call make new friends and pick younger ones. But yeah, I mean, I would call Milt Reitman up, and this kid's in PAT, and he's in heart failure, and I've done this, and this. What do I do now, Milt? And he would just walk me through it. I stabilized some really sick kids in the day.
Well, that was for us over here. Milt Reitman's just down the street.
I know, but he was just a phone call away from me.
Yeah. But you have to have problems with shortages. How did you overcome these things? Like doctors. That's a problem.
That is a problem. It's still a problem. Staffing has always been my biggest problem. It still is, and it is a thorn in my side, and it's very, very hard to recruit. You and I just had a fun experience with that together that also should be shared online. And it's really hard.
It's funny, she's talking about a case where we interviewed the same physician, right? So when the person came to visit us, she says, Dr. Gail said to mention this, that she says hello.
Yeah. Well, I asked her who she was interviewing, and she said, the name of your practice. And I went, "Oh, George."
So we interviewed her. She seemed to be like a nice person. But I said, oh, we're competing with Gail. You know, if I was that person, I think I would take Gail's job because there's a future. I can see the future. You know, I have foresight. Well, she didn't take Gail's job because it was too far away. She didn't take our job because we worked too much. I don't know.
You know why she actually didn't take my job? She wanted to take my job. I could tell the first day I interviewed her. It's because her boyfriend thought it was too far away.
Yeah,
He didn't want to
but
be
it's
far.
the city people.
So Gail, what are the barriers? I would suspect that anytime that you try to get smart people into rural America, they come with a significant other, and that significant other
Always a problem.
needs a meaningful job, right? If I'm married to a lawyer that does corporate stuff, you know, she's not going to want to move to the Hamptons, although now they can't because there's a lot of remote stuff, but she's going to want to be where the clientele is to service and to be successful. So she's going to go, I'm not going to the Hamptons. It's beautiful, but I can't make money there and I'm not going to stay home. Is
It's
that
really
your experience too?
the spousal situation is very often a problem. Yes.
Yeah, I know that.
And then second is, I don't know how much money you make out in the Hamptons, but are your salaries competitive to, with what a health system could pay in, Long Island or Manhattan, or is that also an issue?
I make a lot of money. I do. But then again, I am me. And if you look at my rates, they're not bad. And that is not where I make my profit. I make my profits in my value-based contracting. And I negotiated this a long time ago. I think I was the third one in New York State, and I was ready because I had things in place in advance. DISRIP, I was recruited by Stony Brook, it's like 2 hours away, because I had an integrated mental health program and I had high pay for performance measures, and I was given a lot of money for participating, all legally. Let's, be clear about this, but it wasn't fee for service. It wasn't for the work I was doing. It was for the hoop jumping that I'm good at. So I don't know how my salaries of my staff, compare. Not great. I mean, the hospital is always going to offer more. They are in a position to pay better. They're just recruiting all of my receptionists to work as phlebotomists. It's making me crazy, and paying them $3 an hour more than I pay them.
But how about physicians? Like the starting salary for a pediatrician right now could be from 140 to 250, depending on where they are.
Yeah, I think I'm somewhere in the middle of that, and I'm in a position to offer what I want to offer. I mean, I worry because when you get most of your profit from things that are not contractual, you don't know when that money's going to just stop coming. So NCQA, for example, they are paying $6 per patient per month for PCMH. And when you have thousands of Medicaid health patients, that's a huge income.
But it did start with 8, remember?
Yes. And then they were down to none for 1 month with no notice. And it could just disappear in the blink of an eye. And one year you're making a ton of profit, and the next year you're not. And I don't like to be in a contractual situation where I can't, meet my obligations.
And then how much money would I need to live comfortably in the Hamptons?
A lot.
That's the problem, is the housing is really a problem. It's just really a problem. And so for the people I have, we've been here for a while, but things since the pandemic went from bad to disastrous. I don't know if that bubble's going to burst. I really just am having a hard time predicting what the future of that's going to be, but housing is the issue. And it's not just an issue for the physicians, it's an issue for the, support staff, for the people you pay $20 an hour. There's just no place for them to live, and it's impossible to commute. So the coastal thing, I mean, it's the tip of an island. There's water all around us. There's only one road in and out. And as George pointed out, that's become a horrific situation. They're trying to look at getting, trains in and out, but the problem is once you get off the train, there's no public transportation. There's no way to get anywhere to the office.
Yeah. So, some of the coastal towns in Maryland, the restaurants actually buy houses, and they give a room to their employees for the summer.
Yeah.
Because I mean, if you're a young kid making, I don't know, 12, 15 bucks an hour, cashiering at a restaurant, you're not going to be able to afford to live on the beach.
Yeah,
And
that's what I talked about, the feudal system. So I had a friend, she worked with me on the board of a non-for-profit. I actually founded a non-for-profit. I did. And she married somebody who was running a landscape business locally. And when she got divorced, she got 23 houses as part of her divorce settlement.
wow.
I mean, they were just putting people up in these houses to do the landscaping. Yeah.
Yeah.
Interesting.
And how about student loans? Do you qualify to get any help?
And
No,
that's the frustrating part. I'm going to go on my soapbox again. There's this new grant called Doctors Across New York grant that you theoretically and we should qualify for, because we service the same amount of patients with the Medicaid and Child Health Plus. We're about 60% also as the federally qualified health center or the big evil empires down the street service. Yet we don't qualify. Gail, we lost two candidates. One that came to RBK as a kid, should have come into us, right? But didn't, went to Northwell. The other one was a student that was Dr. Raymond, one of our physicians. He was on the podcast. He was her mentor. She went to pediatrics because of him. She should have, come to us. But didn't. Student loans.
Yeah. Well, I have my most recent recruit is going to be 5 years in July. Had a huge amount of student debt. She worked for me on and off for about 10 years. She did a gap year with me as a scribe. It's one of my first scribes years ago before she went to medical school. Really, I mentored her from her high school years.
Yeah.
And she owed a huge amount of money. And I set something up where she works 5 shifts a month at the hospital, and that qualifies her for loan forgiveness. But in addition to working for me full time, she's also working for them 5 24-hour shifts a month, and it's killing her, and she has to do 10 years of it, and she still has 5 left. And yeah, I mean, I could do that for somebody else because they need people to do that at the hospital, but it's hard and it's challenging to try and recruit for both jobs when I only have control over the one. But
Yeah, but at least I know that doctor. She has a vision. She has a vision. She's a Gail mini me.
I call her the mini me.
She's a
she can complete my sentences. It's really fun to watch us.
Yeah.
Like one mind shared in 2 bodies.
Right.
And George, so would it make sense to look into making the Medicaid side of your practice a rural qualified health clinic? Would that be a possibility?
It probably could be, Gail. Don't shake your head. But
oh my God, do you know what you have to do? You have to give it all control.
Complicated.
No, you have to give it all control. So you can't run it. You have to have a separate board running your practice and do what they say.
Well, that's a federally qualified clinic, not a rural.
Okay, not a rural health clinic. Yeah.
The rural health clinic you still run, you do have to have, you have to hire people because the accounting is so different. But I don't know if they qualify for loan forgiveness too. I know their reimbursement rates on Medicaid, not the quality side, but per encounter is much higher than you get if you're not a rural clinic.
Yeah.
but I don't know if that's something that, I mean, it's expensive to do. It's the accounting
I
is
think you also have to qualify based on your geographic location as to whether or not you're an under.
yes,
Yeah.
yes, but you have to be underserved, don't you think? It's
You
pediatric.
know, if I weren't here, I'd be underserved, but I am here, so I'm not.
Okay, so you don't qualify as underserved.
I've looked into it a number of times.
Yeah. The address doesn't pop up. It was very interesting when I started working at this practice. One of the guys ahead of me said, "Here, you could fill out this form. Put this number down on this yellow application, mail it in, and you can qualify for some loan forgiveness." I didn't know what I was doing. I filled it out. I got some money back. I got mad because I had to pay taxes on it. But that worked out for a couple of years until, I didn't have that much in loans, but it did help. And one of the guys after me, Dr. Riley, I gave him the paper, and he did the exact same thing, and he got rid of some of his student loans, and then it kind of like disappeared.
Well, no, the Biden administration, in one other relief act, allows you to give your employees up to $5,500 a year for loan repayment.
Mm-hmm.
But when your loan repayment is 300 grand, $5,000 a year really isn't going to cut it.
Right.
But at least it's something. It's and anybody can do it. They don't know if they're going. It's going to sunset in 2025, I think. But that's at least something to help.
Well, I'm hoping that with these podcasts and my little soapbox where we talk about the student loan forgiveness programs all the time, maybe somebody of importance will listen to this and take a look at practices like Gail's and ours that service the community that all these other practices also service. So maybe we can get doctors because there's going to be a shortage. It's coming. I mean, it's already there.
It's already here.
But the shortage is, multifaceted, right? You can't work for a private practice coming out of residency because you need the loan forgiveness.
Right.
Pediatrics is a women's specialty now. And many of these people who go to the health system, women or men, are burning out by year 3 to year 7.
Yeah. And
they're just quitting. They don't want to go. And on top of that, if you have $300,000 in student debt to service and they're offering you $140,000 to start, you can't be a pediatrician. I mean, you could make $800,000 a year as a radiologist doing telemedicine and sit in sunny Miami, and your practice is in California, and your cost of living is less, and your lifestyle is better, and you have tons of money to pay your loans. So until they start reimbursing properly for primary care, we're gonna be short. And you see it here. I mean, we have plenty of doctors, too many pediatricians, but you can't find an internist.
They're all at the hospitals.
They're either all hospitalist or they're all concierge. When people tell, "Hey, Herb, who's a good internist?" I'm like, you can't find one.
Yeah,
they're not available.
It's terrible.
But you can find plenty of cardiologists.
But I think the tide is turning to that because we're seeing a lot more people wanting to go into private practice at a later stage in life, not in post-residency.
Yeah.
I'm starting to think that and hope that the insurance carriers are starting to think that there is a value to what we do in pediatrics for the future.
But George, it's not the insurance carriers, it's the government. The government with the AMA decide on the RVU values for each CPT code, and they always skew it on the side of the specialist.
That's not really true. So an orthopedic surgeon will get 300% of Medicare rates, and I'll get 80%. It's the insurance company.
Yeah,
and that, but the RVU too.
Yeah, it's because
but the RVU too.
Really been restructuring the RVUs in favor of primary care, and I can tell you that same evil empire froze my rates, at the 2019 rates, because it was much better for primary care after that, and they knew it, and they just said, okay, take it or leave it. You can resign now, or this is the new rule. So no, it's the insurance companies, and it's supply and demand, and the only thing we have going for us is if the shortage gets bad enough and it starts to impact their ability to sell their plan, they may start to pay more to get what they need in order to be able to have adequate panel roster size and to service it based on government regulations of what they have to have. And they can't, I mean, they're already starting with the stricter, you've got to count people and they can't count 6 times and they can't be dead if they're on your panel.
Right.
Yeah.
Starting to crack down on that stuff.
Let's get into some technology questions, Herb.
Well, I was just going to ask her, have you ever thought about having virtual doctors in your office for the summer when volume peaks?
No, I didn't even do virtual when it was like the thing to do. No, again, I do need to be careful here, but I had a number of patients living in the area, during the height of it. I mean, when it really was like, like you weren't supposed to leave your house and go on the street, and you weren't supposed to do routine checkups in your office, and all of that stuff was banned. There was a lot of doctors from Manhattan doing virtual care on patients who had relocated out here. And I got asked a couple of times to see those patients. And I did have one in particular I brought into the office and had an abdominal mass that was a Wilms tumor in a 1-year-old who was being treated virtually. And I can't blame the guy. I mean, what do you tell the mom to palpate the abdomen and feel the mass? I mean, how are you supposed to do this? I think that some of it is incredibly dangerous. I remember one kid, there were 2, like in one day, there was a kid with a peritonsillar abscess. And I said, let's see your mouth open big, let's look. And it was like really obvious. And I said, you have to come to the office. She was like, I can't. I said, like, I can't give you the IV Rocephin over the phone. Get your ass in here now. And we had another one who I was watching the baby breathe, who was clearly in horrible respiratory distress, and then came in and got, transported out by ambulance. And, it went from virtual to in office to,
You know what? The telemedicine companies will tell you those are success stories.
Yeah, no, but I'm not thinking about that. I'm thinking like Intermountain Health System, for example. They have a lot of very, very rural communities that can only support a nurse practitioner.
Right.
And if, it's much worse than the Hamptons, it's 40 miles to the next ER. And people will come in full arrest with a cardiac event. And they have it set up so that remotely a board certified ER doctor will do the code with the nurse practitioner. So that she's not totally alone till a helicopter gets there to transfer the patient. That's what I think of the potential for telemedicine is if you can get people not at home, but in an office to help with specialty care or volume. But at home is very different.
Care is different than volume. So do I like getting support remotely from specialists for patients I want to try and handle in the office? Yes. Do I want somebody else to see my patient virtually with me not seeing the patient and not present? I don't think that works. I don't have a nurse practitioner that's going to do it. And if anybody's going to supervise her, it's going to be me. And I'm going to do it on site. Now, the question is, should I hire a nurse practitioner to do some of the urgent care services in the summertime? I think that maybe that could be helpful sometimes, but there's no place for them to live out here.
Yeah.
Yeah. So I do have a couple of locum tenens. Do you know Sue Sweezy? She has a house in the Hamptons from Great Neck Pediatrics. Yeah. She's done a week or 2 in the summer out here, for a number of years. And, she just churns out a bunch of checkups when we can't get them done. I do hire, there was a guy from Georgia who, we called him the Georgia Peach. Good looking guy, so sweet, so nice. He now is doing peds ER medicine, but he came his 3rd year of his residency to do a 1-month rotation with me, thinking that he was going to join me, and then decided he'd get a much better lifestyle in Georgia. He would get paid a whole lot more and it'd be much cheaper to live, and he decided to stay there. But he came out every summer, and his in-laws had a house out in the Hamptons, and he stayed for a week, and he worked for me, and he did that for years and years until his in-laws sold the house and left. But yeah, I mean, yeah, sometimes I do get locums to help me in the summertime, but they have to have housing locally, and that's the issue.
Yeah,
Yeah.
that's a big barrier, right?
Right.
That is the big barrier for me, is the housing situation.
Yeah. And none of the non-for-profits, that so many well-to-do people want to address that problem.
Yeah, we have something called the NIMBYs out here, not in my backyard. And there's all these efforts to build affordable housing. And, inevitably an attorney is supported by great wealth to block that from occurring. It's been going on for years. We now have the NIMBYs who are fighting the YIMBYs, but no, the YIMBYs that are fighting the NIMBYs, but and yes, I am a member, and we are trying to push affordable housing and starting to make slight inroads, but it's much too little, much too late. The place is like imploding. It's horrible, and it was really obvious that this was coming, and I was screaming and jumping up and down, and nobody was listening.
So we have a town like that. It's called Middleburg. It's about 30 minutes from my house. And Sheila Johnson, who's a billionaire, wanted to put a Salamander Hotel, which is one of the brands she owns. And that town fought her because, they have all these 50-acre horse farms where people go for the weekend away from their townhouse in Georgetown. And she said, okay, fine. I'm just going to donate the land for low-income housing. And
that got him.
within weeks that they got approval.
Yeah, that'd do it.
Oh, but it must be nice to have that kind of money. Okay, I'll just donate the land and put a bunch of condos here for people who can't afford to live anywhere else.
I have a distinct memory. There was a woman, in fact, she was the niece of that doctor who preceded me, and she wanted to start a preschool. Okay, like who could have bad feelings about a preschool? And she had a piece of property that was zoned commercial and was looking for a variance, and it was on the highway. And there was a zoning board meeting, and she asked me if I would come and speak in her behalf. And my son had gone to the preschool when she had it in the basement of a local church. Okay, and she was just trying to find property and start it, and it's still there, and his child is about to go there. But I went and I testified, and I'm sitting there and listening to the other people testify, and everybody else had prepared and had statistics and data and was speaking, really in an appropriate manner. And I hadn't prepared anything. And I got up and I just sort of spoke from the heart about the importance of daycare for working moms. And I got a standing ovation. And I didn't understand why. All these other people, they politely clap when they sat down, but like, no. And I think that I get it. I really do understand. She didn't get the variance, by the way, and she built somewhere else and has a lovely, pre-K nursery program there. I have been trying for years and years to get appropriate grocery store, appropriate nursery schools, appropriate affordable housing. Let's talk cell towers. So my particular favorite is when I get paged in the middle of the night and I can hear the recording of somebody hysterically explaining the child's distress. And when I try and call back, there's no cell service and I can't get through.
Yeah.
Oh,
it's not safe. It's not, I understand they're not really sweet to look at, and it, ruins the whole, we're in the colonial era look here, but like, come on. Like,
and so, Gail, would you do it all over again?
It's all fascinating.
I don't know. I don't think I'd go to medical school all over again.
No. Opening up a practice in the Hamptons, knowing that old.
Oh, I know. I wish I had done some things differently. And I think I would make some changes. I would never leave here, like my roots are buried deep, 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 and they're gonna bury me here. That's it. I'm not leaving. But it's so hard. It was so hard to do it all. And if I knew how hard it was before I did it, I think I might have been discouraged.
But I'm going to be very inappropriate, and I apologize in advance. But I think being pregnant for 9 months and giving birth to a baby and then raising that baby through college is very, very hard. And sometimes when you look back into it, I think you go, well, would I even do that again? But there's some really hard things worth doing in life.
Yeah. I mean, it was really hard. I think there are easier ways of starting and running a practice. I didn't anticipate some of the changes that occurred in the community. I mean, who can see the future 40 years in advance?
Nobody.
Nobody. If you get to go back in time and start over, I think everybody would make some different choices based on the outcomes that occurred. But no, I'm happy about what I've done. I'm proud of what I've done. I am trying my very hardest to make sure that my practice continues and flourishes after I'm gone. I mean, it might be not possible, but I do want to see things continue for hundreds of years.
Well, if you have the succession plan with the new doctor, I think
but can she run the business? Can she manage without me?
Can she manage everything you've done? I mean, stabilize critically ill children, provide urgent care, be involved in the community, raise a child, have your own farm.
New physicians, recruit more staff. I mean, the challenge. Right. They are building an emergency room down the block from me, and it's going to open in about 2 years. And I think a lot of change is going to come to my practice from that. I mean, things do just keep changing. They really do. I don't think that I will be doing the critical care in the office. I may be walking down the block and doing the critical care there. I don't know. They may not allow me in the door. I think they have their own rules. I don't know. I went to the emergency room. It was July 4th weekend. It was a mob scene, and I got called by somebody. Let's not give those details. And I had worked a long, hard day in the office, and she wanted me to come to her house. She was worried about her son, and he was 9. He woke up from a nap, and he was incoherent and was vomiting and having a hard time walking. And it sounded like an urgent problem to me, but I wasn't going to do it in the house. But I met her in the office, and she brought 2 physicians with her. And when I did the person, place, and time, mental health status, he couldn't think of the word mother. He 9 years old, and he just had this panic look on his face and couldn't say mom. So I, with the help of the 2 physicians she brought to assist me, brought him to the emergency room, and they told me that I couldn't see him there, that I couldn't use their EMR, that I couldn't order a CAT scan. That I had to have the doctor who was there do it. They had just changed everything, and they were privatizing the ER. And I went to the person who was the ER physician, who was a locums and knew me not at all. And I said, I needed to get a CAT scan on this kid urgently. And she said, we don't like to do CAT scans on children. And so I looked at her and I said, well, the head of the ICU at NYU won't accept him until I do. Like, how dare she speak to me like that? But they just wouldn't let me. I mean, I had been at that hospital all of my career, and all of a sudden I had no standing, and I wasn't warned.
So did you have a brain tumor or no?
No, he had a migraine.
Oh, migraine.
Yeah, and I actually suspected it. I asked the mom, any family history of migraines? She goes, well, actually, yes. And at 2:00 in the morning, a mere 5 hours later, he vomited and woke up.
Wow. Well, it's fascinating. This is a fascinating conversation. Thank you so much for your time. I admired you before, but after this conversation, I'm even bigger fan of yours. And what you've done is tremendous for that community.
So there are great physicians everywhere. We just got to look for them. Or actually, they just have to come to us and talk about it and share this wealth of information. Thank you, Gail.
That's absolute. Thank you so much, Gail.
Hiding in plain sight.
Yes.
That is true. Wish you the best of luck out there in the Hamptons.
Go back.
All right. Well, thanks for having me. It was fun.
You're welcome. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.